Welcome to the Biopharma Business Intelligence Unit, where symbolic integrity meets strategic clarity. At BBIU, we go beyond the headlines to decode the structural forces behind global biopharma, AI, and economic realignment. If you value precision, verification, and symbolic depth, this channel is for you. Subscribe now to access our weekly briefings, dossiers, and intelligence reports, and consider joining our institutional tier to unlock early warning systems, custom metrics, and exclusive strategic insight. You're not just listening, you're entering the future of epistemic intelligence. www.biopharmabusinessintelligenceunit.com.
Tylenol, pregnancy, and autism risk between policy shock and scientific ambiguity. Executive summary. On September 22, 2025, the U.S. administration announced a landmark policy linking prenatal acetaminophen, Tylenol exposure, to increased risks of autism and ADHD. The FDA committed to label changes, physician advisories, and a national awareness campaign. HHS further tied the announcement to expanded autism research initiatives and new therapeutic pathways, such as leucovorin. While the White House framed this as a long-overdue corrective to ignored evidence, the scientific record remains contested. A Harvard-led meta-analysis from 2024 found significant associations across 46 studies, while a Swedish mega-cohort of 2.48 million children found no risk elevation once sibling controls were applied. The medical establishment, represented by SMFM and Yale, stresses caution. Use acetaminophen sparingly, but avoid alarming pregnant women without causal proof. This clash between political symbolism, regulatory precaution, and contested science makes the case a paradigmatic example of epistemic ambiguity in public health policy. BBIU Opinion 1. What is acetaminophen? Acetaminophen, internationally known as paracetamol, is one of the most widely consumed drugs in human history. Synthesized in 1878 by Harman Northrop Morse, its clinical introduction was delayed because aspirin dominated the analgesic and antipyretic market. In 1955, McNeil Laboratories launched Tylenol Elixir for Children in the United States, marketed specifically as a safe alternative to aspirin for fever and pain in children and pregnant women. By the 1970s, acetaminophen had become an over-the-counter staple across the globe, with the World Health Organization including it in the list of essential medicines. Its popularity rested on a simple proposition. It relieved pain and fever without the gastrointestinal or bleeding risks of NSAIDs and aspirin. For decades, it was prescribed almost automatically in pregnancy, often considered the default option. 2. Historical misperception of safety. The central paradox is that acetaminophen's apparent safety allowed for indiscriminate prescription, including in pregnancy. Unlike thalidomide or DES, acetaminophen produced no obvious teratogenic malformations. Newborns looked normal. This absence of acute toxicity created a false sense of harmlessness. Yet absence of malformations does not equal absence of harm. Subtle disruptions at the hormonal epigenetic and oxidative levels do not manifest at birth, but rather emerge years later as neurodevelopmental disorders.
3. Evidence of association with neurodevelopmental disorders. The 2025 meta-analysis by Prada et al., Environmental Health, systematically reviewed 46 studies to 100,000 mother-child pairs with national cohorts exceeding 2.4 million births. The conclusion: evidence is consistent with a positive association between prenatal acetaminophen exposure and ADHD, autism spectrum disorder, ASD, and other neurodevelopmental impairments. Odds ratios: 1.26 for ADHD, 1.19 for ASD in exposed children. Dose response: longer or repeated use correlates with higher risk. Critical window: exposure during weeks 8-14 of gestation is biologically most concerning. Contradictory findings: sibling-controlled designs, Sweden 2.48 mem births, attenuate associations, suggesting genetic or familial confounders. However, biomarker-based studies, cord blood acetaminophen metabolites, show 2 to 3 times higher risks in the highest quartiles, strengthening the signal. The navigation guide methodology, borrowed from evidence-based medicine but adapted to environmental exposures, classifies the overall evidence as moderate quality, consistent association. 4. Biological plausibility. How acetaminophen acts on the fetal brain. The mechanisms are subtle but convergent. A. Hormonal disruption suppresses testosterone synthesis in fetal testis, critical for male brain masculinization. Inhibits prostaglandin E2, PGE2, reducing temperature stability and interfering with neuronal differentiation, microglial activation, and astrocyte maturation. These effects are sex-specific. Male fetuses may be disproportionately vulnerable. B. Epigenetic alteration. Induces aberrant DNA methylation in placenta and fetal tissues, silencing genes required for synaptic development and oxidative defense. Transcriptomic studies show immune pathway upregulation in females and downregulation of oxidative phosphorylation in both sexes. C. Oxidative stress. Metabolism yields NAPI, a reactive metabolite normally detoxified by glutathione. Pregnancy reduces antioxidant reserves. Depletion leads to ROS accumulation, damaging neuronal membranes and proteins.
5. Epidemiology by sex. ADHD, diagnosed 2 to 3 times more in boys than girls. ASD, diagnosed 3 to 4 times more in boys, though underdiagnosis in girls is recognized. The epidemiological pattern aligns with the hypothesis: male brains, reliant on androgen-driven organization between 8 to 14 weeks, are more vulnerable to hormonal suppression by acetaminophen. 6. Clinical and therapeutic considerations. General rule: minimize all drugs in pregnancy. Preferred management: non-pharmacological methods first, hydration, rest, lukewarm baths or showers, sponging, avoiding extremes that induce shivering. Only if fever or pain is uncontrolled. Acetaminophen at the lowest effective dose, shortest duration, ideally avoiding prolonged use in the 8 to 14-week window. NSAIDs, generally avoided after week 28 due to ductus arteriosus and renal risks. Opioids, avoided for dependency, respiratory suppression. Thus, acetaminophen remains the least unsafe option, but no longer innocuous. 7. Public health and economic dimensions. The societal burden of ADHD is profound. Direct costs: medical care, therapies, behavioral, occupational, speech, educational support. Indirect costs: caregiver time, lost productivity, comorbidities, anxiety, depression, epilepsy. Macro impact: billions annually in high-income countries. Even if acetaminophen contributes a fraction of cases, the scale of exposure means public health implications are non-trivial. 8. Ethical barrier to randomized trials. No randomized trial will ever assign pregnant women to acetaminophen versus placebo for years to measure neurodevelopmental outcomes. This would be unethical. Thus, society must act on observational evidence, mechanistic plausibility, and the precautionary principle. Conclusion. Acetaminophen is not the harmless drug it was once thought to be. Evidence shows consistent associations with neurodevelopmental risk. Biological mechanisms are plausible: hormonal suppression, epigenetic silencing, oxidative stress. Male fetuses are biologically more vulnerable in the 8 to 14-week window. Clinical prudence dictates non-drug methods first, minimal acetaminophen only when necessary. Public health systems must weigh the potential avoidable burden of ADHD and ASD against the entrenched culture of prescribing acetaminophen indiscriminately. The narrative of safe in pregnancy must be revised. Annex Integrated Research Protocol Title: Retrospective Cohort Analysis of Prenatal Acetaminophen Exposure and Neurodevelopmental Disorders Using Linked Electronic Health Records. 1. Design Type: Multi-Center Retrospective Cohort Study using maternal-child-linked EHR. Population: live births from 2005 to 2025 across health systems with EHR linkage, follow-up of children 8 to 10 years. Exclusion: stillbirths, major chromosomal anomalies, incomplete medication records. 2. Exposure definition: primary exposure, maternal acetaminophen, paracetamol used during pregnancy, captured via prescriptions and pharmacy dispensing records, diagnostic codes for fever, pain as proxies, clinical notes where available. Critical window: stratification by trimester with explicit focus on weeks 8 to 14, window of masculinization and neural organization. Subclassification of exposure: timing, binary indicators per trimester. Duration: cumulative days of use, categorized low, medium, high. Dose: cumulative memcom where available. Pattern: intermittent versus prolonged. Sensitivity to misclassification, probabilistic bias analysis for underrecorded OTC use. 3. Outcomes: primary, ADHD and ASD diagnoses, ICD-10-11 codes, validation when available. Secondary, developmental delay, referrals to speech occupational therapy, individualized education plans, IEPs. Follow-up until age 8 to 10 years or first diagnosis. 4. Stratification by sex of child, male-female, by gestational window, trimester-specific, critical 8 to 14 weeks, by exposure group, mutually exclusive, no medication, A1, pregnancies without pharmacological exposures of interest, acetaminophen only, A2, acetaminophen plus co-medications A3 subdivided by class A3A, SSRIs A3B, antipsychotics, typical atypical, A3C, antiepileptics, valproate, lamotrigine, levetiracetam, A3D, benzodiazepines A3E, thyroid medications, levothyroxine, PTU, methimazole A3F, central antihypertensives, methyldopa, co-medications without acetaminophen A4X, same classes as A3 but no acetaminophen. 5. Confounders. Maternal age, BMI, comorbidities, infections, fever, diagnosis, temperature, smoking, alcohol, socioeconomic proxy, co-medications, prenatal care. Perinatal, gestational age, birth weight, agar, prematurity, mode of delivery. System level, hospital, year of birth, diagnostic policy changes. Sibling design, fixed effects sub-analyses where 2 children per mother are available. 6. Analysis main models, logistic regression, log binomial or robust Poisson regression for adjusted relative risks. Cox proportional hazards, child ages timescale. Comparisons, A2 versus A1, effect of acetaminophen alone. A3X versus A4X, incremental effect of acetaminophen in presence of co-medications. A3X vs. A2, synergy or confounding by indication. Effect modification, sex, exposure, 8-14 weeks. Sibling fixed effects models within mother comparisons to control familial genetic confounding. Sensitivity analyses, excluding third trimester exposures. Negative control exposures, e.g., drugs without plausible neurodevelopmental mechanism. Negative control outcomes, e.g., conditions unrelated to neurodevelopment. Quantitative bias analysis. E-values, misclassification simulations. 7. Reporting relative risks with 95% CI as primary outputs. Absolute risk differences per 1,000 births when data quality permits. Forest plots, dose-response curves, stratification by sex in 8 to 14 weeks. 8. Ethics and governance, use of de-identified EHR datasets, Institutional Review Board, IRB approval, pre-registration, OSF or clinicaltrials.gov, observational, publicly accessible statistical analysis plan. 9. Strengths and limitations, strengths, large sample size, real-world data, long follow-up, capacity to stratify by sex and critical windows, sibling design. Limitations, potential misclassification of OTC acetaminophen, confounding by indication, fever infection, changing diagnostic thresholds for ADHD ASD across time and centers. 10. Feasibility. The global spread of electronic health record systems and maternal-child linkage makes this design feasible without ethical violation. Leveraging these real-world data sets allows refinement of risk estimates, clarification of sex-specific vulnerabilities, and identification of policy-relevant signals.